Log on, tune in, find out. Another good idea from Cambridge.
And then, for most people, as you say, I would agree with that. Because of optimism.
Okay, welcome back to the second session this afternoon. I've been asked to give you a notice which is up there on the blackboard for those of you who can see it. It says, when coming to the wine reception, it's my pleasure now to introduce the remaining two speakers of the afternoon. And first of all, we've got Ian White, who works here in Cambridge, and he's going to talk about a cluster-randomised crossover trial. These are quite rare animals in the field of cluster-randomised trials. So they've got their own complications, but I think, having read Ian's trial, in some circumstances they're extremely useful, and he's going to explain to us why.
Do I need this on? I have a read
Yes, yes, you do.
For the recording.
I was recording, of course.
Yeah.
Posterity, yes.
So you've got to be good.
Nah.
Come back to ownership.
Is that okay? Yeah. Okay, thank you very much, Sandra, for inviting me. I'm going to talk about this particular trial, the PIP trial, that I was involved in. And I'm going to talk about what the arguments were for doing a cluster randomised trial there, and what the arguments were for doing a crossover, bringing this crossover element into it as well. I'm going to talk a bit about the efficiency of the trial, comparing the different designs that we could have used. I hope I'm not going to get thrown out by talking a little bit about analyses. I guess other speakers have talked a bit about analysis too. And then I'm going to finish, having done the whole talk on a sample size of one trial, by trying to generalise and talk about how widely useful this design might be. So this was the intervention that we were looking at in this particular trial. So we're looking at the care of preterm babies. These are babies born at less than 32 weeks, the sort of age where they're going to survive, but they're going to be at quite high risk of neurological and psychological impairment in later life. And it was speculated that one reason might be that the psychological stress involved, both for the parents and for the baby, affects the bonding between the mother and the child. And therefore we're looking at an intervention which can improve that relationship. It's very hard to bond with this very, very tiny preterm baby. So we're looking at a nurse-led intervention to enhance the relationship between... oh dear, I've done nothing. Sorry, I was looking for the... There we go. To enhance the relationship between parent and child, typically the mother, mainly the mother. And we're looking for positive effects on outcomes for the child in particular. So we had a trial, which we call the PIP trial, and this worked in 6 neonatal centres in England, because these very preterm babies are born or referred to particular neonatal centres regionally. We looked at 233 babies, recruited from 210 mothers. That's a level of clustering I'm not really going to come back to, but it's mildly relevant, I guess. And each centre admitted, on average, roughly 3 preterm babies a month, and the babies stayed on average a couple of months in these units. We spread recruitment over a year, and the intervention was delivered by specially trained research nurses. The comparison was usual care, and the outcomes included parental stress at 3 months, plenty of that, and child's mental and physical development at 24 months. I don't need that anyway. Okay, so what were the arguments for cluster randomizing? Well, Alan has been through a general list of arguments, and certainly 2 or 3 of those were relevant here. The main one, I think, in the minds of the investigators was the need to avoid contamination. So if you're going to have, on average, about 6 preterm babies on each unit at any one time, if you randomized individually, knowledge about the intervention is going to filter from the one group to the other, and that was felt that it was worth avoiding. But also there are practical and logistical reasons, because this way it meant that the intervention was delivered in fewer centres. The research nurse didn't have to visit all 6 centres, but only had to be at 3 of them, so less travelling and just logistically more convenient, potentially leading to better compliance. Problems with cluster randomizing here, Mike talked about this. It's the recruitment bias. It's the issue that concerned us most. Necessarily in a trial like this, the recruitment is going to have to take place after randomization, because you are recruiting these babies as they are born preterm. There's no way you can tell in advance who is going to be born preterm. So recruitment bias could arise mainly through differential consent. That is, a mother is told, we are running this trial, do you consent to have it to be part of the study? You will be receiving the new intervention or the control intervention. Ethically, we had to say that. And we will be concerned that the sort of people who do consent will differ between the 2 randomized groups. There's no great way to deal with this. We addressed it by trying to maximise the consent rates. Clearly, we hit 100%, we'd have been fine. We didn't think 76% was too bad, and we really wanted to have similar consent rates across the 2 arms. Perhaps not a great surprise that there was more consent in the intervention arm than in the control arm. Obviously, the intervention arm is some amazing new thing which is going to infuse people more. Of course, similar consent rates is not enough to guarantee that you're getting comparable people consenting in the 2 groups, but it seems a good start. So again, I think this is an issue. Another problem with cluster randomizing, of course, is that power is likely to be very low with only 6 centres. And this we address by the crossover part, which is coming next. And a third problem, I think, is that, not an insuperable problem, but that the analysis must allow for clustering. And if you're dealing with clinicians who would really rather like to be using very simple analyses, that is something of a problem. Okay, so that was the cluster randomized element. Now the crossover element, which we haven't been talking about this afternoon so far. So crossover trials are typically used in individually randomized designs to reduce the impact of between individual variation and hence improve precision. So the standard crossover trial would be a drug trial. They don't have to be, but that's the commonest use, I think. Perhaps in a chronic disease like asthma, so comparing 2 different inhalers, people get one inhaler for 1 period, measure their symptoms, then get another inhaler for a 2nd period, measure their symptoms at the end of that, and compare. So the idea is that because individuals will have higher or lower levels of symptoms, you can reduce or remove that level of variation. Well, the same argument must apply to clusters. Clusters are very likely to have higher or lower levels overall, so by using a crossover element, we should be able to eliminate that level of variation and hence hopefully improve precision. So the way we did this was that we allocated each centre to one intervention for 6 months and then the other intervention for 6 months in a randomised order. And the allocation, just to be clear, applied to all the babies who were born in the centre within that 6-month period. So in the 2 periods, you've got different groups of babies. The main problem with the crossover design, absolutely generally, is carryover. That is the phenomenon whereby the treatment in one period may affect the outcome in later periods. So in drug trials, this can occur most obviously if the drug is actually physically still in the system and is still having its effect, but there may be physiological or even psychological effects remaining. For example, in pain relief trials, the effect of pain having been resolved in one period can often have quite a long-term consequence. In a cluster randomised trial like PIP, how could we have carryover? I think it could still arise if... So the issue is, does giving the intervention in the first period potentially affect outcomes in the second period? And I think that's got to be through the presence of the same individuals in the two periods. If it were parents who were present in both periods or staff who were present in both periods. So the standard way to avoid carryover is to have a washout period, a term obviously designed to apply to drugs in the body. In PIP, we had a 3-month washout separating the two 6-month intervention periods. So this was long enough to be pretty sure that there will be no families who spanned the two periods. And from a staff point of view, because the intervention was delivered by specially trained staff, they would not be there in the control period. So the only risk of carryover would be through standard members of staff who would clearly have been there in both periods, but they weren't being trained. So we felt we were probably okay for that. The other problem with the crossover design, again, is it complicates the analysis a bit. Again, not insuperable. I just want to draw a distinction between two possible cluster randomised crossover designs. This is like the one that I'm talking about in PIP, where you have relatively short stays. So each of these arrows is meant to refer to one baby and their 2-month stay, on average, within a 6-month intervention period. So clearly different babies in the two periods. Whereas you could actually have a cluster randomised crossover design with long stay, with sort of chronic illnesses, where you had the same patients in each period, measured at the end of the one period and the end of the other. I think that would present more problems, but it's certainly not an impossible design. Carryover then in the two designs has slightly different implications. Here the carryover is only really going to be occurring at institutional level, whereas in this design carryover clearly could happen at the individual level as well. And so it's probably going to be harder to avoid carryover in this case. It's probably only going to be suitable for chronic diseases like the asthma I mentioned earlier. So that's the reasons why we did the design, and I hope that's made it clear the design that we did use. A little bit about efficiency. This is a fairly straightforward hierarchical model for the cluster randomised crossover design, where Y is the outcome and assumed quantitative, which is what we had in our trial, for the case individual in the Jth period in the ith cluster, allowing for a fixed effect of period, an effect of treatment, X is the treatment, 1 for intervention, 0 for control, and then allowing for random effects of cluster, of period within cluster, and of individual within period within cluster, all assumed normally distributed. So in this model, beta is what we're interested in. It's our intervention effect of interest. And I'd like to compare 3 designs here. 3 designs, all with kn individuals per arm, an individually randomised trial with just kn individuals per arm, a cluster randomised trial with k clusters of size n per arm. I'm sorry, I'm using different notation. Everyone else this afternoon has used m for the cluster size, and I'm sorry about that. And a cluster randomised crossover trial with k over 2 clusters of size n per arm over 2 periods. And despite everything Sandra has said, I'm going to talk about efficiencies with equal cluster sizes because it's much easier to do it. And in particular, the estimated intervention effect is simply the difference of the means in the two on intervention and control. So there's the model written up again, and these are the variances in which I think I've omitted a factor of 2 in all of them, but it doesn't matter because we're comparing. The variances of the estimated treatment effect. So for the individually randomised trial, you can see the standard thing that all the variance components are divided by nk, whereas for the cluster randomised trial, the between variances are not divided by n, only by k. And for the cluster randomised crossover trial, you don't have the between clusters variance. That's eliminated. So if you just compare the magnitudes of those, you can see that the cluster randomised trial is always inferior to the individually randomised trial, always got a smaller variance, so that's been commented on before. And that the cluster randomised crossover trial is going to be superior to the individually randomised trial if the between periods variance is very small, and it's going to be superior to the cluster randomised trial if there is variance between clusters. The best design may depend also on the numbers of degrees of freedom available for constructing tests and confidence intervals, and I'm not really going to go into that, but I just want to note that is an issue.
Yeah, could you just explain in words what sigma v squared is again?
Oh, sorry. So it's the variance of this random effect. So that means the period-to-period variation within a cluster. So we're assuming that things happen in these clusters that cause rates, outcomes to vary over time, and it's that variance. Okay. Okay. I just want to note that whereas in a standard cluster randomised trial there's an ICC, in this design there are two ICCs because there are two variance components, and we found it useful to think of an ICC corresponding to the variance that Simon just asked me about, an ICC between periods in the same cluster and an ICC between clusters. And necessarily this one is smaller than this one. So I'll use that again in a minute. Okay, so that was efficiency. I'm now going to talk a bit about analysis. And there's been some discussion already this afternoon about different methods of analysis. We wanted to work out whether we needed to use a cluster level or an individual level analysis. Working with clinicians, it was clear that they would much prefer a cluster level analysis, something that they could more readily understand, but we felt it was important to consider at least the individual level analysis based on hierarchical random effects models. So I'm going to do a little simulation study comparing these. We're going to consider first of all equal cluster sizes. Now with equal cluster sizes, all methods give the same point estimates, so there's no issues of relative efficiency. And further, all methods are unbiased, even with unequal cluster sizes, so there's no issue of bias. The main thing we're interested in is how good the standard errors are, which are going to assess through coverage in the case of equal cluster sizes. And then in the case of unequal cluster sizes, we're going to look at efficiency. So these are the individual level analyses considered. Again, I've written the same model up there, which we're going to use for the analysis. First of all, model 1 was simply to fit this with all of these as random effects. Model 2, we had the option in this particular design of letting the U's be fixed rather than random effects. So we considered that as an alternative. And then what I've called M2 minus, whereas these models constrain all the random effect variances to be non-negative, this one allows the between periods variance to be unconstrained. It allows a negative variance. And you'll see the impact of that in a moment. And these we fit all of them by restricted maximum likelihood. Then we looked at some cluster level analyses. So these ideas are adapted from the standard analysis of a crossover trial. You define D as the crossover difference. In other words, the mean for that cluster in the intervention period minus the mean in the control period. And define W as +1 or -1 depending on the order of the interventions across the periods. And then the intervention effect is beta in this model, which is a linear regression of D on W. I find it quite pleasing occasionally to be interested in the intercept of a regression model rather than the slope. The slope represents the period effect here, which is not of primary interest. And this model, this regression model, can be estimated in various ways. We considered an unweighted, in which we simply fit it by ordinary least squares, in which case the estimate of beta is simply the average of the average D in the one order and the average D in the other order. you can weight by the harmonic mean of the sample sizes in the two periods for that cluster. And that would be optimal with ICCs of close to naught. Or you can weight with a weight that properly allows for the ICCs, and that's a more complicated expression which I've not put up here, but which you can use. Clearly, the choice of weights only matters with unequal cluster sizes. If all the clusters are the same size, then they all come to the same thing. So that's the analyses we considered. So here is the simulation study. These are coverages with 6 clusters of equal sizes. We've got 20 individuals per cluster per period. Along the top, you've got a range of ICCs for period and for cluster going from 0 to 0.1. And then these are the individual level analyses and the cluster level analyses. They're all the same. And there's really only one thing to see here, which is that these coverages are all around 95%, whereas for these methods, which force the variance components to be non-negative, you get quite dramatic over-coverage, especially down here, when the ICCs are naught. Now, when you think about it, this is not really surprising. The true ICCs are naught, so the estimates can either be negative or positive. If they're negative, you push them up. If they're positive, you don't push them down again. So clearly, you're going to have over-coverage. And you can see that the over-coverage tails off, although it doesn't completely disappear, over here. So forcing variance components to be non-negative leads to over-coverage. And also, interestingly, the cluster level methods implicitly do allow negative variance components. So that was our conclusions, our findings, for coverage. Let's just look at the other question, which is the relative precisions of these techniques with unequal cluster sizes. We took cluster sizes within each period to be Poisson with mean mu, which was 15 or 25. So varying cluster sizes. Having heard Sandra's talk, I wish I could tell you what the coefficient of variation was. It's probably not 0.65 here, but it's probably not that far short. No, it's probably a bit short of that. The same designs along here, the same ICCs, the same models, although here the cluster analyses do differ. And just look down the columns here to compare different analyses for the same design. You can see there's very, very little difference. I've put this row in bold because the unweighted analysis is slightly less efficient than the others. I think the worst is 5% less efficient here. So you do lose something by doing the unweighted analysis, and you really lose very little otherwise by using this, for example, sample size weighted analysis. So our conclusions for the PIP trial were we decided that we would analyse the trial using cluster level methods with these harmonic mean sample size weights. So weight the first set of weights. We also decided that we would adjust for individual level baseline variables by a two-stage procedure in which we first regress the outcome on those covariates, adjusting for cluster, extracted the residuals, and then applied the two-stage procedure to those residuals. But when it came to assessing interactions between intervention and individual level covariates, we felt we needed the hierarchical models. So we analysed for interactions in that way. It's all published, but since this is about design, I'm not going to give you any results. I do just want to raise an awkward point, and Sandra sort of touched on this as well. When it actually came to analysis, in a preliminary analysis, unfortunately it was preliminary with a preliminary data set and wasn't still there in the final data set, I found a negative estimated variance component for a particular analysis. And hence I found that the standard error allowing for clustering was smaller than the standard error not allowing for clustering, which clearly can happen if ICCs are negative. Sandra mentioned putting the ICC up to 0 in that case, and I think we felt the same, that there was no way we believed that there was a negative ICC actually. Of course, you could make an argument, as Mike did, that the intervention was a scarce resource. There was only so much intervention that the staff were able to give, and parents were competing for it. But I don't think we really believed that in this particular case. So there's just this conflict here that having done the simulation study and shown that you have to allow negative variance components in order to get the correct coverage, actually when it came to it, well, if you like, we bottled out. We didn't believe that. I'm not quite sure if that makes me a Bayesian rather than a frequentist, and I'd like to hear your comments on that. But it seems to me that correct coverage is not the most important thing here. Now, although I'm talking about this in the cluster randomized crossover trial, it's a situation that can arise in all cluster randomized trials. Okay, so to conclude, I think the advantages of a cluster randomized crossover design are efficiency compared certainly with the cluster randomized design, and convenience possibly compared with an individually randomized design. The disadvantage, let me come back to this recruitment bias. In a one-period cluster randomized trial, you can avoid recruitment bias by listing and getting consent for all individuals before you randomize. I've certainly done that. I just insisted that I was provided with the membership of every cluster before I randomized them. Now, very commonly, you can't do that. And I can't imagine any situation where you might have a two-period trial and you were able to get the complete lists before the start of period one. So you may disagree with me, but I find it very hard to think of any situation where you'd avoid recruitment bias in this design. How does recruitment bias arise? It could possibly arise in general, I'm thinking not just in PIP, if eligibility is under staff control. So the nature of your cluster is, and in PIP it was all babies born in that unit in that time period. So if babies were being sent to these particular hospitals because the intervention was available there, that would clearly cause potentially some bias. And if the date of delivery was determined by the availability of the intervention, then that would cause some bias as well. I think probably those are both fairly implausible in the particular PIP case, but in general these would be issues. And then of course there's the other one that I've discussed already, the differential consent, which seems like probably in general the bigger threat to validity. And the disadvantage, I think, of a somewhat complicated analysis. And now I'm actually going to generalize beyond my sample of one. I'm going to go up to a sample size of 3 trials now, because here are 2 other examples of the use of this design. This one is in the Lancet a couple of years back. They compared 2 policies for ordering chest x-rays for patients in intensive care who were mechanically ventilated. So this was, I think, chest x-rays were routinely done every day versus on request. So they had different policies in different periods in the same intensive care unit. I think my only concern about that would be I'd be a bit worried about carryover, because if the policy has been implemented by the very same staff in the one period as in the next period, then it's quite hard to see how you sort of wash out that policy from the staff. The second example I rather like. This was evaluating feedback about cardiopulmonary resuscitation performed outside hospital by paramedics, ambulance staff. So this feedback was meant to help them in real time improve the way they were doing their CPR. And interestingly, in this one, there were not just 2 periods, clusters alternated between feedback on and feedback off over from 2 to 5 periods. I'm not sure about the use of alternation there. We don't normally go for alternation rather than genuine randomization at each time. Although I wasn't also sure how periods themselves were defined. So I think that's interesting, and that sounds like probably the sort of design that might well be free of carryover and may well be free of recruitment bias, because in an emergency situation you may well be free to recruit everybody. So in summary, it seems ideal for evaluating policy type interventions which can be switched on and off, provided that you can address this issue of recruitment bias. That's my one-sentence summary. Just want to acknowledge the people I worked with on the PIP trial and a couple of publications, and on the methods project and our publication from that. So I'll go back to that slide and finish. Thank you very much.
Sort of slightly missed. Did the staff switch from one hospital to the other then?
Only the nurse who was actually, the research nurse who was delivering the intervention.
Just the one nurse?
She moved, yes.
Yeah.
Obviously, the remaining staff stayed put.
And do you think, you use 6 centres, do you think that's about the minimum you could possibly get away with, even with to improve the power by using a crossover?
Yeah, well, 6 wasn't great, was it? But that was, as you well know, that was what was available. that was what we did.
Yes.
Seems a bit dubious going below 6, doesn't it? Yes.
It does, yeah.
Yes, I think I'd agree. 6 is a bit dicey, really, isn't it?
Just another slight comment, is we had a slightly similar paramedic team where they brought a paramedic with the ambulance, and it was either on duty or off duty. So they were on duty for a week and off duty for a week. So, and we randomised them in pairs. So we had another crossover chart.
Okay. Yeah. Mm-hmm.
What was the impact of the carryover effect, which is, of course, the biggest disadvantage of the crossover design in general, would be different in the 2 different designs you mentioned at the beginning.
Yeah.
Presumably it would be much worse when it's the same patients.
I think so.
Well over time than if it's different patients, where perhaps you can rule it out in advance much more easily.
Yes, I agree.
Yeah.
Yeah.
What about the control treatment? How different is it from the treatment? Is it the regular things what the hospital usually do for those children?
Yeah, I mean, control was treatment as usual. They just carry on doing whatever.
Then you don't think it's a more period for those groups who get first treatment then control, because they are already in control, then getting treatment then control, and other group getting control and then treatment, right?
Sorry, do I think it's...
So one group is getting first control and then treatment,
Yeah.
another group is first treatment then control.
Yeah.
The second group already getting control, then treatment, then control, right? If it is
Okay.
the set.
But you're talking as if it's the design where it's the same individuals. Remember, it's not the same individuals getting control, then treatment, then control. It's the staff are. So the staff who are routinely there will see intervention come in and then go away again. And you're saying that's going to
Because
affect...
all the time they are getting control, right? Those staffs.
Well, they're delivering the control care, yes.
And there's only few days they are getting treatment. So do you think that period effect will be estimated same one?
Do I think that
Period effect.
the period effect?
Yeah.
Okay, the period effect. The period effect is simply the average in the second period minus the first.
Yeah,
Well, that responds to calendar time, season. That's to do with that sort of thing. I don't see a problem, but yeah. Okay. You had a question?
Probably not the old idea of Marvin Zeland not to ask consent if you're in a control
Yes.
group.
Yes.
So I wonder if something like this will, yeah.
I think yeah.
Who says it's the next step?
Well, that's certainly the ethics angle. Yes. Yeah. Perhaps I think that might be the right way to answer your question. But on the Zeland designer, there's some interesting work. I don't know if you've seen it. Qualitative research on parents of very seriously ill babies preterm, not this trial, who were asked what they felt about the Zeland design versus other designs, and they actually they quite strongly seemed to feel that the Zeland design would sort of been cheating them somehow. They actually had quite a strong preference for the standard design. Which I think surprised a lot of people. But I think this feeling that somebody was randomising them and not telling them about it was unpleasant.
In your study, you included this sigma v squared, which I'm still slightly trying to get my head around.
Okay.
It doesn't, I think, have a parallel in individually randomised crossover trial. And in your particular case, you found that it was, well, obviously near zero. It was negative in one stage of the analysis. So, I mean, would you advocate that you always include this variance term in the model, or could you imagine situations in a particular applications where you would argue that that variance component, was zero and you wouldn't include it in the model? Or is it a bit like sigma u squared? You say, well, actually, if you do this design, by the nature of the design, you must include this variance term.
I think I'll go for the latter. I mean, it has the same role, I think, as the sigma u squared in a cluster randomised trial, in that if you assume it's naught, you're basically just treating everything as independent. I suppose my argument why it ought to be there is that things do happen in hospitals over time. Staff leave, policies change, and they could cause outcomes in different hospitals, some to improve, some to deteriorate in a systematic way. I mean, that strikes me as a very plausible thing to happen. And I suspect that would generalise. About to comment. I suspect that would generalise to many other settings as well. That stuff happens in clusters in ways that vary over time. I should think that's very widely true.
Okay, if there are no more questions then, let's thank Ian and